Hello, everybody. I'm Rob Wallace here in St. Paul, Minnesota. I'm an evolutionary epidemiologist with the People's CDC, here with an update on the COVID-19 pandemic. This week, we'll cover the state of global COVID, the state of U.S. COVID, and the public health personnel who are trying to convince the American people that COVID is no big deal. We begin with global COVID. In the graph in red, the Johns Hopkins Coronavirus Resource Center reports us steady at another 3.2 million new confirmed COVID cases worldwide for the week ending October 16th. The number of global weekly deaths there in white declined to 9,500 confirmed deaths this past week. In green, we see a bump up to 30 million new shots administered this week worldwide. This New York Times map shows hotspots over the past week in Europe and Asia. Not much has changed from last week. There in purple, the surge in Europe continues, centered in France, Germany, Austria, Slovenia, Italy, and Greece. Taiwan also remains an epicenter in average daily new cases per 100,000 population. As we can see from these percent changes in caseloads the past couple weeks, rebounds there in the warm colors are spreading across the globe, including Canada, Chile, Paraguay, Honduras, and a sudden sharp increase in Suriname. All of Western Europe except Portugal, although at a lesser rate than last week, a sharp increase in Turkey, parts of the Middle East, a greater increase in China, as well as in Papua New Guinea and New Zealand. And still that wide swath in Africa, although something of a retreat in Southern Africa. At a time when most countries other than China have rolled back non-pharmaceutical interventions like mask mandates, although this is from 2 weeks ago, clocking in at no more than 60% of the containment and health index measuring such interventions. And at a time when the vaccine strategy many governments say they're pursuing, instead, is failing. Much of the world is at best vaccinated for variants no longer circulating. We see uneven campaigns in booster vaccination across the world. On the one hand, Chile, Peru, Uruguay, Cuba, Belgium, Finland, Germany, Italy, and Japan show top-tier booster campaigns. In contrast, we see near nothing in Russia, India, Pakistan, Indonesia, and those even reporting in from Africa, and a mediocre campaign in the US, Mexico, and Eastern Europe. The collapse in vaccination, hand in hand with the rollback in the non-pharmaceutical campaigns that vaccination campaigns depend on, is occurring exactly when multiple Omicron subvariants are circulating across large expanses of the world. Last week, we showed this the case from multiple countries reporting their genetic sequencing. This week, we show the change in time for one country, for France, as a representation of what's going on for the most part in global north. While previously, left to right, one variant replaced another, we see multiple Omicron subvariants co-circulating, including BA 2.75, BA4, BA5, and the burst of new subvariants we've been talking about over the past couple episodes of COVID this week. Indeed, Raj Narayanan announced his lab has tabulated 500 plus Omicron sublineages as of October 20th. Here, just the 36 BQ.1 sublineages. Not only do we see here the veritable zoo of new subvariants now circulating, a mix of sons and daughters of BA2 and BA5, but that many in the colored circles are converging on the same molecular adaptations or combinations of new amino acid replacements that allow the different subvariants to be resistant to monoclonal antibody treatments for COVID. That is, Omicron is evolving out from underneath many of our biomedical interventions. Daniel Focosi, who made the previous diagram, summarizes the present state of SARS-2's resistance to these therapeutics. He declares remdesivir as costing $2,000 per patient and expressing contraindications in viral rebounds. The same for Paxlovid. He declares molnupiravir doesn't work and is mutagenic. Evusheld is at 40% resistance, and bevtelovimab, unavailable in the EU, is clocking in at 20% resistant. It's not that you shouldn't take these if you need to, but that they aren't the silver bullets they may be presented as. They may work exactly right in some patients, but not in others. SARS-2 is also escaping our natural antibody responses. Last week, we learned XBB and BQ.1.1 demonstrated record immune escape while retaining their capacity to bind the ACE2 receptor that's studied across our own bodies. Here, new work by Nicole Hatchman and colleagues show the US-specific BA4.6 that's been driving the outbreak in Appalachia, And as the top chart shows, with its own unique amino acid replacements in the spike protein, it induces the lowest neutralizing antibodies compared to the original gangster Wuhan strain and BA1, 4, and 5. That's the case on the left for patients with previous Omicron infection, and on the right for patients with just the first set of vaccine shots and with the set of boosters. So the pandemic isn't over, in spite of President Biden's declaration last month, even as the outbreak in the US continues its apparent retraction. This New York Times map shows almost the whole of the country is presently characterized by a relative decline in COVID cases per 100,000 population. Although Kentucky and other counties in Appalachia remain a stronghold, and we do see a slight lift in the floor of cases in the Four Corner states and in the Northeast. Hospitalizations for COVID are low across the country, except in an interesting burst in the Charlotte, North Carolina metropolitan region. But we are forced to take all these metrics at face value. It doesn't help that hospitals and health departments are following the CDC and NIH's lead and adhering to looser reporting standards with, as we discussed last week, the CDC rolling back reporting. Gregory Travis reports here that more than half of US states aren't publicly reporting COVID statistics. And it doesn't help that the now popular home tests aren't reportable as in other countries. Other modes of following COVID-19 are patchy at best. We see the levels of SARS-2 virus detected in the wastewater that comes through our sewage plants, a leading indicator of the pandemic, indicates much of the country in cooled-off blues. However, sewage plants in orange and red representing SARS-2 loads of 60 to 100% more than their previously recorded levels are found in the Pacific Northwest, Utah, Colorado, Illinois, Wisconsin, Michigan, and across the Northeast. The more acute measures of changes in sewage loads over the past 15 days show red flare-ups of 1,000% or more of SARS-2 detected, suddenly on the West Coast, in states in the Rockies, Nebraska, Illinois, Wisconsin, Michigan, the whole of New York State, including down into New York City and the rest of the tri-state area, and the Southeast and the Gulf states. So what comes out of our behinds may be telling us what's ahead. To sum up, here's the People CDC version of our present community transmission by county, mapped by our own Les Schaffer. It's the combo of caseloads and test positivity that the CDC plots, but unlike the CDC, the People CDC differentiates the high level of danger counties are subjected to beyond 10% COVID positivity into high, very high, and extremely high exposure. Down at the bottom, we see that the People CDC also now differentiates exposure by both the percent of counties and by the percent population. We see here that population, we're down to less than 45% of the American people are in communities subjected to high to extremely high COVID exposure. Another 40%, however, is subjected to substantial exposure. As in the Times map, the COVID outbreak continues its retreat, even with hotspots in Alaska, the Four Corners, parts of the Northeast, Michigan, and Kentucky. Although Iowa, which was an early adopter of reducing COVID reporting, doesn't read right, as if the border was enough to keep COVID from spilling in from here in Minnesota and Wisconsin from one end and Missouri from the other. But just because we all are understandably exhausted by this pandemic, and just because the political class took employer direction to send us back to work, doesn't mean the virus is over us. Along with the surge in Europe, we see SARS-2 evolution continuing stateside, with the B5 variant being replaced by the BA4.6 subvariant we talked about earlier, as well as BF7, BA2.75, and now the hyper-infectious BQ1 in Kelly green and BQ1.1 in the dark green coming on strong, with all those other supercharged sublineages we talked about only starting up. The observations about exhaustion and evolution are not unconnected. As health psychologist Mike Horger observed, with a near whole of our interventions stripped back and only 35% of Americans with any booster, quote, it's almost like unmitigated spread lets viruses evolve, end quote. And we'll add, vice versa. Last week, I talked about how such short-sightedness appears more a feature of American public health than a bug. But short-sightedness has a connotation of a mistake, when in fact, it is very much a matter of intent. Here, in the face of the oncoming winter spike, CDC Director Rochelle Walensky somehow misses out recommending masks for airborne respiratory diseases, instead recommending an ill-aimed hand hygiene program. She also recommended those of you with stomach aches should put a Band-Aid on your arm. But it's more insidious than passing tweets. As alluded to last week, we learned earlier this year, Impact Research, the Biden administration's polling firm, suggested that the administration, quote, declare the crisis phase of COVID over and push for feeling and acting more normal, end quote. And you can't take that away from the administration. They followed through with stripping out requirements that hospitals report daily COVID deaths, overflow in ventilated COVID patients, and critical staffing shortages. With the additions, or rather subtractions, we described last week, ending daily reports on cases, vaccinations, and likely soon hospitalizations. Ending public health chat boxes and COVID travel notices country by country. By repeatedly declaring the pandemic over, the administration greenlighted Congress to refuse to continue to fund testing, treating, and vaccinating the uninsured. No more free access to monoclonal antibodies, no additional oral antiviral treatments, and scaled back purchases of preventative treatments for the immunocompromised. Less funding for next generation COVID vaccines, even less of a push for vaccinating the rest of the world, much less the US. Each of these, an additional step down from an earlier abandonment of broader public health programs such as eviction moratoriums, stimulus payments, monthly child benefits, and the Paycheck Protection Program. This isn't just a COVID thing. The state overall has a class character, and this administration has been front and center on following Capitol's lead and pushing off the blame and damage of this year's spike in inflation on working people. Even as more than half of the growth in unit price in the non-financial corporate sector, that is, corporations that make physical products you buy, more than half of the rise in prices are attributable to corporate profits there at the top in the dark blue, and not in input prices or in wages. But this isn't just a matter of the political class. This is an effort supported by the core establishment of American public health. Here's a panel of the Infectious Disease Society of America that includes David Leonhardt, the Times columnist who on a near weekly basis minimized COVID as a public health danger. Also on the panel was academic economist Emily Oster, who downplayed COVID to get kids back into school. As Abigail Curtis and Justin Feldman described in May, Oster's work was cited by key government officials of both parties as rationale for reducing COVID protections, including by Florida Governor Ron DeSantis and CDC Director Walensky. Curtis and Feldman write on Oster's popularity among officialdom. Quote, Oster's books popularize what Elizabeth Pop Berman calls an economic style of reasoning, which emphasizes individualism, market-based choice, and efficiency, while deprioritizing concerns related to injustice or collective well-being, end quote. The panel also included on the far right there, Infectious Disease Society of America President Carlos Del Rio. Del Rio, as Feldman reminds us, served as a consultant for Delta Airlines and signed off the first signature there on its successful missive to the CDC demanding that the agency roll back its recommendation of 10 days quarantine for COVID infections to 5 days. But they're all over the place. Leanna Wen, a prominent minimizer, was invited to talk at the American Public Health Association annual conference this year. Members of Biden's own COVID advisory board published an op-ed in the New York Times about what the US is still missing for the next emergency. And there's some good stuff in there, but all premised under the notion that the problem here is twofold. The authors don't describe the interference they ran for the Biden administration's efforts to roll back COVID control efforts they demand here. And secondly, they write as if the problem is the next pandemic, as if this one is already over. Indeed, Michael Osterholm of the University of Minnesota, one of the authors here, owns a perfect record at defeating every potential pandemic, but pivots away on an NIH dime when it comes to speaking about the failures of the powerful during an actual outbreak. Indeed, the authors here miss that it isn't just poor planning and a failure of governance that killed over 1 million Americans, but concerted policy choices in the face of all the evidence. We'll end with an archetypical minimizer. Here's how philosopher Loreto Torrago replied to this Princeton alumni weekly piece on Lucy McBride. Quote, while Black, Brown, Native, and low-income people continue to be sickened and to die at much greater rates than whites, Dr. McBride has worked tirelessly to deprive them of the protective measures poll after poll shows they desire. Instead of trusting people of color know their needs best, Dr. McBride hides behind the slogan of individual responsibility, as if she could or should convince Black mothers that one student wearing a mask in an overcrowded classroom where windows don't open and the HVAC is antiquated would be adequate protection. She has continually dismissed the dangers of COVID, including long COVID, which she wants to distinguish from long pandemic, a condition characterized by depression of her own invention, as if the well-established biomarkers of long COVID didn't already do that. She has said the cure for coronaphobia, another pathology of her own invention, is contracting COVID. Whether or not COVID cures anyone with coronaphobia, they'd have to survive it first. Despite her admirable focus on mental health, Tarago continues, McBride insists that kids return to normal, that is, be denied all the protections like testing, quarantines, and so on that schools used to have in place as policy. Vulnerable kids are not unaware that the choice to abandon these hard-fought protections is a choice to abandon them. But that awareness of abandonment, despite its devastating consequences for mental health, does not interest McBride beyond endorsing the platitude of one-way masking. McBride says her concern is with inequity, but inequities, and the health inequities COVID makes plain, are social problems that require conscientious citizens and policymakers to commit to their correction at the social level. Personal responsibility is not responsibility at all. It is a mere excuse for the abandonment of responsibility for social goals, end quote. Coronaphobia, interesting. Antebellum doctors similarly diagnosed slaves with an irrational impulse to escape plantations under the diagnosis of drapetomania. We're not equating here slavery and a pandemic. We're focused on the source of these diagnoses. Well-compensated and connected doctors and scientists pathologizing people's objections to unbearable conditions lucrative to the well-heeled and powerful. And these people are only the few of what is now an industrial production in denialism. Big picture, this is why working people need to organize themselves to force the state to act in their class interests, which in this case is focused on the weird notion that everyday Americans have the right to their very lives. And that's COVID This Week from the People's CDC. You can learn more about the People's CDC and read this week's COVID weather report at our revamped website, peoplecdc.org.